Hi everyone. We'll start in another minute or two to give people the chance to join the call. All right, everyone. It's 6 o'clock, so I think in the interest of time, we'll get started. So I just wanted to say hi to everyone, to our hub members, our participants, our speaker for today, as well as our case presenter. For those of you who are new, welcome to our echo session on HIV and aging. And for those of you who have been with us throughout all our previous sessions, welcome back. Our session today will be focusing on men's health in people growing older with HIV. So, for those of you who have missed our previous sessions or who are new, you can actually access the recording and our previous slides and resources on the iEcho platform that led you into the Zoom. So, with that, I'm just going to hand over to Farah, our new coordinator for Echo, for some housekeeping and announcements before we start. Farah, over to you.
Cool, thank you, Tuli. Hello, everyone. So, there's a quick housekeeping or like announcement. So, hold on, sorry. Uh, just be reminded to change your name on Zoom to your name, your area of expertise, and also your country. Like how currently you can see my name, police name, and some other people are doing. And then during the session, you can put your questions in the chat box, and we also encourage all of you to turn on your video so we can see each other and like engage better in the session. And also to please be mindful to use the mute button if you are not speaking. And just like Puli said, the session will be recorded and uploaded on the iEcho platform. So for currently, we do have translated captions enabled. So to those who are not speaking English as their first language, you can enable this caption language to the language that you prefer. So for CPD hours for Malaysian, Australian, and Japanese clinicians, you will be getting your CPD hours by joining these IFO sessions. For Japanese and Australian clinicians, you don't have to do anything. You will send your name to the JSLR and ASHM. But for Malaysian clinicians, we will need you to fill up the Google form later that will be sent in the chat box so that we can use your information and send it to the MMA. Yep. Uh, So today we'll be doing men's health as Polly said. So I guess for housekeeping and announcement, that's all from me. I guess another one is feedback forms will be sent at the end of the session. And yeah, I will come back again at the end of the session to remind you guys with some housekeeping and announcement. I guess going back to you, Pearlie.
Thanks, Farah. So, with that, I'm going to introduce our speaker for today. Our speaker today is Dr. Tristan Barber. He is a consultant physician in HIV medicine at the Ian Charleson Day Centre, Royal Free Hospital, and Honorary Associate Professor at the Institute of Global Health, University College London. Tristan established a dedicated frailty service for aging patients with HIV infections in 2019 called the SAGE Clinic. He has a research background in HIV-related neurocognitive impairment and antiretroviral clinical trials. His talk will provide background on aging and frailty in people living with HIV, with a particular focus on men's health and issues that men with HIV may experience at a younger age or more severely, and cover approaches to screening as well as providing integrated and holistic clinical care for these individuals. So thank you, Tristan, and welcome.
Thank you very much for the kind introduction. It's really nice to be able to speak to you today. I'm just going to share my screen. I've got a very short 20 minutes, so I'm going to move fairly quickly through my slides. Hopefully those are sharing okay for you now. They're not showing up in the same way they did earlier. Okay, thank you so much. There we go. Great. So we're going to talk about men, aging and HIV. And as we heard, we're going to start by thinking a little bit about aging and frailty in HIV quite generally. Now, I wanted to start out by thinking what we're really trying to achieve when considering frailty and aging in people with HIV, because I think it's very important that we don't pathologize people with HIV by saying to them, take your treatment, you can have a normal life expectancy, but then adding in other concerns and problems such as, oh, you might become frail earlier than other people, you might develop problems sooner. So I think we need to recognize that this is a possibility, but also provide people with the tools to avoid becoming frail and to remain healthy into older age. And really, I think this feeds into what we want to achieve in terms of achieving good health-related quality of life. We know by diagnosing people early, by putting them onto antiretroviral therapy, and by achieving viral suppression, we can achieve the U equals U target. We can achieve good statistics, such as in the UK, where we think we have about 97% of people perhaps being undetectable. That's those who know their status and who are engaged into care. But we want to look beyond viral load to make sure that we're providing a quality service. For me, this also feeds into the popular press, if you like, that HIV is fixed. It's one pill once a day and it's easy. On one hand, I think that's true. On the other hand, I think for people living with HIV, it's our responsibility to look at things that might occur earlier or with more severity and support people to remain well into older age. And so we want service delivery that promotes wellness and not just survival. And this leads us into thinking about the fourth 90, which is this good health-related quality of life. And you can see my terrible drawing on the right-hand side here, which is my idea about quality of life, that it's not a fourth 90 getting smaller, it's an overarching quality of life that is there for at least 90 or 95% of all people living with HIV. Now, what are some of the problems? Well, we know historically that people with HIV may have had multiple problems above and beyond the HIV on its own. People may have multiple other outpatient appointments for comorbidities. They may need to engage with primary care services. They may have basic needs that are not met, including social needs, including financial needs. And they may struggle with polypharmacy and in addition, issues around their mental health. And this can often lead to people falling between the cracks in terms of their different care pathways. And it may be that for many people with HIV, the people they trust most highly are their HIV clinicians, their HIV clinics, and people providing their HIV care. So to what role can we, as HIV specialists, step up and help support coordination of complex care for people with HIV who are getting older? And what we really want to try and move towards is the middle section here. So in the past, we've often seen people developing frailty, presenting late and in crisis, resulting in admission to hospital with uncoordinated, fragmented medical care. And what we want to move towards for all people, but certainly people with HIV, is that an older person who's living with frailty or developing aspects of pre-frailty is identified so that we can introduce preventative, proactive care by supported self-management and personalised care planning, and keep people in the community, hopefully in their own homes, maintaining their own independent activities of daily living, with support from different agencies and different care providers that's coordinated and person-centered and holistic. So a few quick questions we're going to cover. What is frailty and how might we measure it? What's special about people with HIV? How can we intervene to reverse or prevent frailty? And in the context of this talk, what issues might we see that affect men in particular? Well, frailty has been proposed as a measure of biological as opposed to chronological aging. And what you can see here are two 83-year-olds. The one on the right-hand side has the same medical problems as the one on the left-hand side: hypertension, high cholesterol, and a prior myocardial infarction. But we can see just by looking at him that he has taken more proactive steps to keep himself healthy. He looks fit, he's on a running track, he's smiling, he looks healthy. Whereas the person on the left looks overweight, is using a stick, so has possibly lost some muscle strength, looks a bit more depressed, sad, lonely, and isolated. I mean, it helps for this image that one is in black and white and one is in color, but that's not the point of the images. And you can see that the person on the right, if something happened to them, if they had an infection, a cancer, or if they fractured a bone, they probably are more robust, they have more reserve to deal with that particular problem. Whereas the person on the left looks more vulnerable. If they were to get a new infection, perhaps a pneumonia or a new cancer, or if they were to fracture a long bone, it may take them much longer to recover. And it's this variable vulnerability among people of the same chronological age that's known as frailty. Now, we know that the proportion of people living with HIV globally who are aged 50 years or above is increasing. This is happening more markedly, actually, in low and middle income countries where the absolute numbers are higher. And from 2000 to 2016, we can see the proportions doubled in many geographical regions around the world, in fact, tripling in Latin America and the Caribbean, and quadrupling in Asia and the Pacific regions. And we know that older people living with HIV experience higher rates of key comorbid non-AIDS events. And this is just a graph replicating that. So the proportion of people living with HIV who are aged 50 years or above, we can see it's increasing in higher income countries at the bottom in blue, but actually the absolute numbers increasing in low and middle income countries in orange. So this is not a problem that we could ignore. Now, there are a couple of theories about HIV and aging. It's whether HIV is really a model of accelerated or accentuated aging. So accentuated, meaning that problems occur at the same ages, but more often in HIV than in people without HIV. Whereas in accelerated aging, cancer, other geriatric syndromes and other problems may occur earlier compared to people who are not living with HIV infection. Now, in reality, of course, we see a little bit of both. We see some things occurring more commonly, certainly some types of cancer, and we see some things occurring earlier, including perhaps some frailty syndromes. Now, for me, this is changing all the time because not only is it dependent on your birthday age, it's of course also dependent on your HIV age. How long have you been living with HIV? And when were you diagnosed? Were you diagnosed before 1996 when we didn't have successful HIV therapy? Or were you diagnosed after 2015 when we had the START study and we knew it was the right thing to put everyone onto HIV treatment regardless of CD4 count? And I'll come on to that again a little bit later. So frailty is defined as a state of decreased homeostatic reserve resulting in increased vulnerability to endogenous and exogenous stressors and an increased risk of negative outcomes. And we can define it with indices to capture different aspects of frailty. There's a pictorial reference index, the Rockwood index, which helps us determine what stage of frailty someone might be at. There's also a described frailty phenotype that asks questions around slowness, weakness, weight loss, low activity, and fatigue. And there are also objective measures like timed get up and go tests and grip strength that we can easily introduce into clinical practice. And often you just know someone's frail when you see it. They may be having a dysregulation in multiple physiologic systems, and it can be associated with high vulnerability. Now, I'm not going to dwell on this slide. I'm very happy to share my slides from this talk, but just to show that there are various things that can feed into someone's risk of frailty. Not all of them are HIV related. You can have factors related to your education, socioeconomic status, social vulnerability aspects, neuropsychiatric factors, and lots of other medical problems in addition to some of your HIV factors. But you can see here in the HIV related section, years with HIV is also listed. And this adds to my argument, I think, that we have to think about someone's HIV age as well as their chronological or birthday age. And frailty doesn't need to be permanent. If we can identify frailty or pre-frailty early, then we can put in interventions to try and reverse people to a more robust state. This is a diagram of the frailty phenotype, and this really reflects the questions we ask in our own clinic to try and identify people who are developing frailty or pre-frailty. So by asking 5 questions around walking speed, weight loss, fatigue, and activities of daily living, you can identify whether someone is robust, whether they're scoring 1 or 2 points on this questionnaire and may be pre-frail, or whether they have 3 or more aspects and are fully developing or potentially developing frailty, needing further investigation. And this is the modified questionnaire that we ask. You can see the questions here to score and try and identify that frailty phenotype at an early stage. The clinical frailty scale is the other scale that's used very often. This is the images here reflect the different stages of frailty. This can be very useful when you're seeing someone in an acute clinical situation. We use the clinical frailty scale in our emergency department to try and identify people's stage of frailty so that discharge planning can begin very early to reflect the complex needs they may need to discharge them from hospital after an acute event has been treated. Now, what's actually going on? There are a number of things that can feed into the development of frailty in people living with HIV. You can see these described very well in this diagram here, but noting 2 of these aspects are related to HIV itself. There may be an impact of HIV reservoirs affecting inflammation. There may be residual HIV proteins that are leading to premature processes of aging. And of course, some antiretroviral agents, particularly some of the older antiretroviral drugs, may feed into the development of problems that lead to frailty in addition. I think particularly of body fat changes from the early antiretroviral era, as well as peripheral neuropathy that continues to cause people problems into later age. Now, this is what I mean when I think about HIV age. This is the way I usually break people down in my own head. You can be 70 and have been diagnosed in 1990 when you will have been told that you might have had a 5 to 10 year life expectancy. You may have had an AIDS-defining condition. You'll have been told there wasn't successful treatment for HIV, and you may have suffered multiple bereavements, including the loss of partners. After 2015, you could be 70 and have been diagnosed in 2020 and been told to go onto HIV treatment immediately with well-tolerated triple therapy. And I think those two 70-year-olds are very different individuals. And that's why I think it's important to think about not only the birthday age, but the HIV age in addition. I include 96 to 2005 because this is when we had early triple therapy that was very effective, but not always very well tolerated. And 2005 to 15, when we had better tolerated triple antiretroviral therapy, including integrase inhibitors. And I think these four groups of people age in very different ways. What can we do about it? These are the European guidelines that recommend promoting comprehensive geriatric assessment, aiming at personalized interventions to make people well for a lifetime and avoid admission to hospital, identifying medical, psychosocial, and functional limitations, and aiming to maximize overall health. But on a practical level, if we think someone's developing frailty, we should try and improve physical function. Referring to exercise programs or for physiotherapy assessment can be useful here, particularly if balance is a problem. We can refer people for dietetic advice to try and improve nutrition and offer psychological support where available to try and improve psychological status. We should ameliorate physical deficits by referring people for further assessments, including management of other comorbidities, and where possible, improve physiological reserve and treat other medical conditions. Now, some of the targets we may intervene with are listed here. I won't go through all of these individually. Some are perhaps easier to address than others. I think addressing social isolation and loneliness can in particular be very difficult issues to address, but these do negatively affect the development of frailty. What about antiretrovirals? I think in older people, we should use antivirals with the least potential for drug-drug interactions. We also need to acknowledge that drug handling changes with age and that drugs that people have tolerated for a long period during their life, perhaps when they're younger or during middle age, may cause side effects or problems in later life. So we need to constantly review people's antiretroviral regimens and offer simplification where this is possible. Just to finish with a slide on men specifically, before I move to a question and my closing points, what things might affect men in particular? The issues we see affecting men particularly are issues around sexual functioning. Of course, we need to rule out physical causes for lower libido, but very often we end up not discover anything physical that's causing sexual problems and may need to support people psychologically. We also, of course, have to look for prostate issues in men as they get older. We know that PSA screening is not the best way to screen for prostate cancer. We have a large trial running in the UK at the moment looking at the use of MRI screening for prostate cancer, which I think may well be the best modality, but of course will be limited by access, and we need further details on what age to start this screening and how regularly to screen people. And isolation and loneliness, particularly for older men who have sex with men who may have lost people in the early stages of the AIDS epidemic, can be a real issue, and as I've mentioned, can be very difficult to address. So just before my conclusion slides, I wanted to ask a very quick question for you to vote on. Management of issues related to aging in people with HIV should be mainly coordinated, and this is in your opinion, and in your own local environment. Do you feel that issues related to aging in people with HIV should be coordinated via primary care services and in the community, by referral to elderly care specialists, within HIV services by a multidisciplinary team, or with a combination of the above approaches, or something else, something completely different? So I'm hoping you can vote on these now. And if not, I'm going to move on. And we can come back to them later in discussion anyway. So some take-home messages. Frailty is common and can present earlier in people living with HIV and is associated with a higher burden of comorbidity and an increased risk of mortality. While the prevalence of frailty differs between countries, with the addition of pre-frailty, this represents a large proportion of older people living with HIV. Where possible, we should screen for frailty, probably annually, in all patients living with HIV over 50 years old. And we should adapt and ensure strategies are in place to support those living with HIV and frailty. How best to do this remains unclear and often will need decision in your own local environment. We know that the management of frailty will be cost-saving because it helps to keep older people with HIV independent in their own homes and out of hospital. And it may be within our own services that we can reapportion time saved on stable patients to allow better evaluation of frailty in those who are more complex. We may need a way to risk stratify people beyond our standard CD4 and HIV viral load assessments. This may include the time of HIV diagnosis as well as people's chronological age, and may include other risk factors, including isolation and loneliness. Where possible, we should personalize management of people who are developing frailty in the context of HIV with an individualized management plan focused on the quality of life and prevention of disability. And men may need specific support around sexual functioning and prostate screening in particular. These are my contact details. I will stop sharing here, and I'd be very happy to take any questions in the time we have remaining. Thank you.
Thank you, Tristan. I'm just trying to see if we can share the results of the poll.
Yeah, got it. Thank you. So a combination of the above, yeah, that seems like a very, very sensible approach. I would agree. There's no one right solution, I think, for any individual service.
Yes, I think it looks like about 78% said combination of the above. All right. So yes, thank you for your talk. I have some questions, but maybe I'll leave it to the floor. Right,
Jenny.
Oh, Jenny has a hand raised.
Thanks, Tristan. That was great. My question, we also have in our national HIV strategy that actually we're not as aiming as high as you are with 90% good related quality of life, health related quality of life. In our national strategy, 75% should have good quality of life. I'm wondering how you actually measure that and how do you determine that 90% of your patient population have good quality of life?
Yeah, we're very lucky. It's a really good question, Jenny. So we're very lucky in the UK that we have a Positive Voices survey, which isn't done annually, but it's done every 2 to 3 years, where a sample of it's around 2,000 people with HIV from across the UK are sampled to complete quite a detailed survey. And they do report data on their health-related quality of life. What's really neat about Positive Voices is you get a breakdown for your own clinic, and it shows you, a bit difficult, it shows you what percentage of your clinic, of the respondents from your own clinic, have an identified problem in a certain area. So it might be domestic violence, it might be psychological support, it might be complex comorbidity management, it might be help with benefits. And then it shows what proportion of those respondents said that their need was met. And so you can identify within your own clinic where there's a huge disconnect between need and met service, and then target your services accordingly. And that's a really useful resource. So not only do we get some quality, health-related quality of life data from that survey, but also we get a direction of travel as to where we might go to tailor our services to improve overall health-related quality of life. On an individual level, of course, we can use things like patient-reported outcome measures. We can sample our own clinic populations. We found that when we used a health-related quality of life questionnaire, specifically in our dedicated frailty clinic, people got questionnaire overload. They got a bit tired filling it all out. And some of our older people, there were questions on sexual functioning. They would cross it through and just put not relevant, or they would cross. So bits they thought weren't relevant to them, they would cross through. And it was actually very difficult to get good data out of that. And look at whether or not it was improving or worsening over time. So I agree, it can be challenging, but with I think our probably the most useful for me is our national survey data from Positive Voices.
Thanks.
Thanks. Tristan, I have a question. Just, in terms of talking or focusing more on men's health specifically, what are your thoughts about anal cancer screening, and that? Is it routine or?
So we just had at the British HIV Association conference a couple of weeks ago in Brighton, we've just had presented the draft new screening guidelines for anal intraepithelial neoplasia in men and women, which will essentially offer screening for everyone from age 35 and above. And we'll start with high-risk HPV testing, followed by cytology where available, and high-resolution anoscopy for those identified as having a combination of high-risk HPV and suspicious cytology. At the moment, that's not out for consultation. We have been slow in introducing it in our own service, but we are at the moment just trying to get the high-risk HPV testing off the ground. I think one of the concerns is about the availability of high-resolution anoscopy for diagnosis and for treatment. One of my interests is in topical treatment for low risk or low, I've gone blank, not for HSIL, for low level intraepithelial lesions in terms of, sorry, to go back, the Anchor study looked at HSIL, so highly significant intraepithelial anal lesions, and the majority of treatment in Anchor was laser hyfurcation, and that there were insufficient numbers of people in Anchor to make an assessment on outcome from topical treatments. Now, anecdotally, in my own experience and with colleagues in the UK, many people get good resolution of low, why have I forgotten the acronym? Someone fill me in. LSIL. So low significant, no, it must be low. I'm having a senior moment. For low risk lesions, many people report that with the use of topical treatments like imiquimod, they do see reversal of those. Now, the risk is if you don't do an HRA and biopsy, you may miss HSIL. But I just wonder if there is some, and we don't know the answer to this at the moment, but whilst we don't have enough capacity for HRA, rather than not doing any screening at all, I just wonder if actually there's a holding measure for some in terms of topical treatment to reverse. Thank you. Low-grade squamous intraepithelial lesion. Fantastic. Thank you very much indeed. Very helpful. I just wonder if there's a holding measure with the use of topical treatment so that we don't overload HRA services. And then in lower resource settings where people aren't able to access high-risk HPV testing or anal cytology, the recommendation is still monthly digital anorectal examination. There have been some studies in MSM looking at the acceptability of partner anorectal examination, which seems to be sometimes acceptable. So I think where you don't have anything, at least you need to examine the anorectum for palpable lumps and refer those early to surgical services. But I think screening criteria will become better understood and more widely accepted as there are more guidelines coming out internationally, but it will depend on your access to high-risk HPV testing and to anal cytology, which is not without its own problems.
Thank you. And for the high-risk HPV testing, would that just be a swab?
Yep. Can be a self-taken swab. Anal cytology does need to be healthcare professional performed because I think the evidence is that self-taken cytology swabs don't yield enough in terms of cells for anal cytology. But HPV testing can be a self-swab.
Yeah, I think that's something that we probably don't do enough. And with that screening, do you foresee it being done in GP in primary care or in, hospitals?
So again, I think this very much depends on the setup. I don't know the setup so well in Malaysia, but in Australia, I know there's a lot more primary care physicians that are involved in HIV care. In the UK, our primary care services are totally overwhelmed, so they would expect this to fall to highly specialist care. So it would happen within our HIV services. And of course, we're hoping that we'll see the same dramatic impact on anal cancer with HPV vaccination that we've seen on cervical carcinomas. So, we are vaccinating in the UK. We vaccinate men who have sex with men up to the age of 45. So I guess our hope is that by introducing some screening now, hopefully in 10, 15, 20 years, we'll start to see the benefits of screening, benefits of vaccination in that population earlier.
Okay, thank you very much. I think that's all the questions from me. If there's no other questions from the floor, we might move on to our next session, and then we can continue on the conversation. But if anyone has questions for Tristan, please feel free to put it in the chat box. Sorry, Tristan. But thank you so much for your talk. So we're going to move on to the case presentation. So I'm just going to welcome our case presenter, Dr. Daniel Wong. Dr. Daniel Wong is a general practitioner working in an urban setting in Melbourne, Australia. He has undertaken further training in the management of HIV, hepatitis B, C, and drug and alcohol dependence. He also has an interest in refugee health, sexual health, as well as transgender health. With that, I welcome you, Daniel, to present the case.
Thank you very much. And thank you, Tristan, for a very, very thought-provoking presentation. And thank you, Jenny, for inviting me to give this presentation. Can everyone hear me okay? Thumbs up. Yeah, cool. Excellent. I'm just going to start by sharing my slides. So it's a bit of a complicated case presentation, and I've been told I've got 10 minutes, so I'll try and make it snappy, and then we can move on to the discussion, the interesting bit. So, yes, the patient I'm presenting, a 72-year-old Caucasian Australian male, living with HIV. In terms of social history, he owns his own home. He lives with a regular male partner of 7 years. His partner is also elderly and is actually an overseas national who doesn't yet have permanent residency in Australia, so isn't eligible for aged care or other kinds of services here. My patient has, though, a good network of friends and family that are very supportive, and he himself gets support from Aged Care Services and Thorn Harbour Health, the new name for the Victorian AIDS Council. Mainly, he gets help with domestic cleaning and shopping assistance. He's independent with ambulation with use of a four-wheel walker. He was diagnosed with HIV in 1984. His CD4 cell count at diagnosis was 10. He had a CD4 and a D of 0. Over the years, he had a number of AIDS-defining illnesses, PJP pneumonia, disseminated MAC. In 2013, he was also diagnosed with stage 4 plasmablastic lymphoma, which thankfully is now in remission after chemotherapy and radiotherapy. So with his long history of treatment on older ART regimens. He's had a number of different treatment-related complications, including peripheral neuropathy, severe lipodystrophy, dyslipidemia. He's also had a case of previous renal impairment to TDF, which resolved on cessation of the agent. He has also himself had AIN3 treated in the 90s with radiotherapy. So this is a graph showing over time his ART regimens. As you can see, it's a complex history, and it's not really the focus of the talk, so I won't dwell on it too much. But just to say that he really is one of these sort of original patients diagnosed in the early 80s who, as Tristan mentioned, had a long period without effective treatment. He started on AZT monotherapy, then he went through dual therapy, and then he was on a early unboosted protease inhibitor regimen. Essentially, he started having successful virological suppression since about 2007. And he's been on his current ART regime since 2016. So at the time, he swapped from boosted darunavir, etravirine, lamivudine, and raltegravir to his current regime of dolutegravir and Descovy, which is TAF and emtricitabine. And that change was made in 2016 in the hope that it would be sort of more a modern regime that was more metabolically favorable. Uh, he's, so he's been stable on treatment with virologically suppressed for a long time, and his CD4 cell counts have averaged around about 400 in recent years. He has a large number of different comorbidities, long-standing type 2 diabetes, ischemic heart disease. He's had a LAD stent in 2017. His last angiogram in 2022 showed the stent was working fine, and he just had mild residual coronary artery disease. He had a successful TAVI in 2022 for severe aortic stenosis. He has chronic kidney disease stage 3A, so his eGFR, I think, is usually around 45 on average. And this is the etiology. This is confirmed to be diabetic nephropathy from a renal biopsy that was done in 2005. He has benign prostatic hypertrophy. Last year, he had toxic multinodular goiter requiring a total thyroidectomy. He has extensive osteoarthritis affecting multiple joints. He's had multiple joint replacements. He has osteopenia, gout, lipodystrophy, dyslipidemia, and depression and anxiety. This is his current medication list. So his ART regime, as I mentioned, dolutegravir and Descovy. He's on insulin as well as metformin and Glixambia, which is empagliflozin and litagliptin. He's on ramipril, aspirin, rosuvastatin, esomeprazole, allopurinol, levothyroxine, mirtazapine, cholecalciferol, magnesium, and his as required medications, paracetamol and cloxone senna. So just to break this presentation down into the three main discussion points I wanted to highlight. The first issue really is the combination of his sarcopenia and his frailty and the recurrent falls. There's a number of contributing medical factors to his long-standing frailty and sarcopenia. He obviously had a lot of significant weight loss with his initial AIDS diagnosis and long period of time without effective treatment. When he was on AZT therapy, he developed a myotherapy related to that. Then again in 2013, when he had his lymphoma diagnosis, he was very unwell with this. He had only 2 rounds of chemotherapy before he had severe complications with agranulocytosis, polymicrobial sepsis, hospital-acquired pneumonia, seizures due to hyponatremia. So he had a prolonged ICU admission where he also had a lot of muscle wasting, critical illness, myopathy, and that was followed by a long-standing rehabilitation admission after that to try and recover. He really was quite close to death during this time period, but amazingly, after only tolerating those 2 rounds of chemotherapy, he achieved remission from his lymphoma. And then again, he had a further insult with weight loss and muscle mass loss with his hyperthyroidism last year, requiring a total thyroidectomy. Other factors that affect his mobility, he's got severe osteoarthritis, multiple joint replacements, peripheral neuropathy, which is multifactorial related to his older ART regimes, but also type 2 diabetes and vincristine exposure during his lymphoma episode. So recently he had a subacute admission at the Alfred, the statewide HIV hospital in Victoria. So they have a subacute ward where people who don't have acute medical issues necessarily, but have long-standing kind of medical issues that need multiple teams to kind of be involved and investigate. They can have an elective admission for a period of time to do a number of tests and get a number of teams involved for a workup. So my patient had one of these admissions. He had multiple investigations done, CT, chest under pelvis, gastroscopy, colonoscopy, rheumatology review, rheumatology screening. Essentially, there were no kind of other easily reversible causes found for weight loss and muscle mass loss. So his current management that came out of that, he's got connected with physiotherapy services. He gets a weekly exercise program guided by physiotherapy, hydrotherapy 1 to 2 weekly. He has a dietitian, who provides him a meal plan and protein drink supplementation. He takes vitamin D supplementation. He also recently had a psychiatry review as well for his long-standing depression and anxiety. He was on long-term zopiclone for insomnia, and they decided that they would withdraw that and replace it with mirtazapine to try and treat his depression, but also maybe to bolster his weight and his appetite. Second issue to highlight is sexual health needs. So he has long-standing erectile dysfunction, evidently multiple causes for that, both physical causes, vascular disease, type 2 diabetes, polypharmacy, and then probably psychological causes as well. So, it's something to think about. As Tristan mentioned, he really grew up in this period where, HIV was not just considered a death sentence, but also, something was before the era we had effective treatment, before this idea of U equals U. So he had a lot of stigma and shame, and, this idea of disclosing HIV to sexual partners was very traumatic for him. And he obviously has a lot of shame about his body image in terms of the changes that have been caused by antiretroviral therapy. We have tested testosterone levels on a number of times, and they've all been normal. He's tried multiple different treatments for his erectile dysfunction. He's tried all the kind of tablet PDE5 inhibitors. He's tried multiple injectable agents as well. In 2018, prompted by this new relationship, his current relationship, he decided to see a private urologist who specializes in erectile dysfunction. And the urologist really said, you've kind of gone through everything. The next thing we could consider is a surgical treatment, so a penile implant. But he decided kind of not to pursue. And I think the erectile dysfunction, it's not just an erectile dysfunction. There's also, in general, a lack of libido, a lack of interest in sex as his frailty increases and his energy levels decrease. His partner is HIV negative and is still interested in sex. So, this has caused some issue in the relationship. And the third issue I just wanted to highlight was about his bladder and bowel function. In terms of his bladder function, he's got problems. So he's got BPH, he's got urinary frequency and urgency, and episodes of urge urinary incontinence, likely due to his BPH, also his type 2 diabetes, probably the contribution of polypharmacy. I know he's on SGLT2 inhibitor as well. And there's an element of functional incontinence. When he gets an urge to go with his limited mobility, he simply can't make it to the toilet in time. Previously, he has trialed Durodart, but he didn't find this particularly effective, so he's not on any treatment for that, particularly in the moment. In terms of his bowel function, he's fecally continent, but he has issues with chronic constipation, likely due to his his comorbidities and his poor mobility. He requires a regular regime of aperients. Sometimes he needs suppositories as well. He has a chronic tenesmus, which has been investigated in the last year by the colorectal surgery team, and it's thought to be due to a pelvic floor dyssynergia. So they noted that when he makes attempts to evacuate his bowels, it's a paradoxical tightening of the anal sphincter. So that leads to a reduced evacuation of the bowels. Probably contributing to this is that history of previous treatment for AIN with radiotherapy. He's got a chronic perianal dermatitis requiring regular tacrolimus ointment. We have done for him, I have done a digital rectal exam in the last year, which was normal and no sign of rectal cancer. And that's the last slide. So I'll open up for discussion. Thank you for your time.
Thanks, Daniel. We'll now perhaps ask some of our panel members and also Tristan for some comments on how we can address some of these issues. So if we go back to the first issue of sarcopenia, frailty, and falls, what other strategies do you think we should be considering for this patient? And I wondered whether Preeti might talk to us about medications that might increase the risk of falls and how we should ensure that we check our medication lists for any medications that might increase that risk.
Daniel, do you think you could share your slides
Yeah.
again, maybe just to bring up the medication
Yeah.
list?
Yeah, that's a good idea. Let me just get back to that. There we go.
Thank you.
I mean, he's clearly on a polypharmacy. It would be wonderful to be able to eliminate some of those medications. And in fact, our HIV specialist pharmacist, when he had that subacute admission, did try to do that. And I'm sure Kajar will tell us that that's something that the geriatric physicians do when they do geriatric assessments, is to try to eliminate unnecessary medication, which often are added when there's an acute event, but then never stopped. But Preeti, when you look at that list, is there anything that concerns you that might increase his risk for falls, given his mobility issues?
Um, well, I looking at the list here. Mm, okay, there's empagliflozin, which I'm not sure if he's having any polyuria that may increase his that can may increase his risk of fall, considering his frailty and mobility issues. So empagliflozin should be relooked at. And another drug that I see is esomeprazole. I think the prolonged use of esomeprazole is also another, there's risk of bone demineralization for long-term use of PPIs. Besides that, well, I usually take some time to really go through these drugs, but yeah, I think yeah, another one would be mirtazapine. There's also a risk of exacerbation of memory loss and also cognitive impairment. Yeah, I from a very fast look on the list, these are some of the drugs that I think can affect his mobility, and probably we should look for other alternatives.
Just
Thanks.
ask, what's his HbA1c and what's his renal function?
His renal
Uh,
function is 67 if I'm
I would have that on the yeah HbA1c.
Um,
From memory, oh yeah, 6.9 was the last one. So that makes me think there's
HbA1c.
scope in terms of empagliflozin to come off. I wonder if he's known to an endocrinology team as well for this, and I wonder if there's an element and a renal team as well. So his eGFR is actually it was 67, so it's pretty good on the last one. Yeah, I was going to say that maybe the empagliflozin was being used for renal protection, but more than anything. But yeah, there could be scope for that to come off. And I take the point about the mirtazapine, which I think the psychiatry team considered maybe a lesser of two evils to kind of replace his long-term Zopiclone that he was using for years and years and years, which also has those kinds of cognitive and falls problems.
Tristan, can I ask you about the study that was done in the UK that looked at certain medications that increase the risk of falls?
Yeah, so we've had a
Oh,
couple presented, Jenny, looking at anticholinergic drugs in
yeah.
particular. One was from Jessica Doctor at Guy's and St Thomas's who looked at this. I was just trying to find them actually because there are a couple of good online scoring tools that allow you to put in medicines and look at their cholinergic score, I think, and what they might be adding in terms of risk. And I sent them to someone recently, but I just can't find the email at the moment, which can be quite useful. But so, yeah, highlighting those drugs that particularly can be additive in terms of falls risk. I think what's really strong for us in our frailty service is having a geriatrician who is very happy to de-prescribe. I think many of us as HIV specialists feel nervous about de-prescribing things that aren't from our expert or aren't within our area of expertise. But actually, what he's very good at is very gently deprescribing things and writing to prescribers and explaining why he stopped them so that people don't feel upset about having their drug discontinued by someone else. But of course, as people age, we can see, a change in the risk of a change in the benefits and risks of individual agents. And often, I think from individual prescribers, they don't often see the overall picture. So it's really nice when someone can step back and have a look at that. Rena, thank you for
Yeah,
putting the
yeah, I
coordinator
agree.
in the chat.
And thanks, Rena, for putting in the anticholinergic burden calculator into the chat, and that'll go up onto the platform for people to be able to use. This man, actually, it's very painful to watch this man stand up from the sitting position. He has such weak muscles in his legs that his head goes forward so far and he hyperextends his knees when he's standing to get onto the four-wheel frame. And it does take a lot of effort and it does take a lot of time. The physiotherapy that has been started, I don't know whether Julia would like to talk about any other approaches that we might use to try to actually improve his muscle, particularly his quadriceps function. He is doing that 1 to 2 weekly hydrotherapy. I think he might have just restarted the muscle strengthening exercise program. I think he might have taken a little break from that for a little while, but has gone back to it. But is there anything else that we should be thinking about in the way of rehabilitation or physiotherapy for this man?
Thanks, Jenny. I'm sorry I can't switch on my camera. I'm on the road now. All right.
Okay.
So I'm trying to imagine how he moved with all those sarcopenia and on top of that, osteoarthritis, right?
Yeah.
Yeah. And well, that's how good is his upper limb in terms of because I can imagine when he stand and he walk, he depends a lot on his upper limb, and that can lead to other pains. But in terms of strengthening, I'm still questioning myself. How much can we improve in terms of his muscle strength when you look at his age and all his comorbids? And yeah, because in terms of regaining strength, you are supposed to increase the load on a regular basis for the muscle to gain. So I'm not sure is his physiotherapy, is it sometimes we just do it to maintain and not to actually aim. We are not expecting improvement. So that is something I'm not sure of, because sometimes it's very passive and it is not meant for improving. I can't really think of anything extra. I mean, we can have seats to stand. I don't think we will use anything with electrical stimulation on him. So it can be painful as well. I can imagine it's very painful. And hydrotherapy is good because there's buoyancy and it's not very painful. But whether it will improve the strength or not, that's still my question, because you need a lot of resistance to improve your strength. So really, I mean, for me, has his condition was described. What I want to see him in front of me and really assess it, because yeah, I mean, I'm not I can't be sure that there's anything I can do to really improve his strength at this point of time, unfortunately.
Okay, thanks, Julia. So our physiotherapist actually expressed some concern about his driving. So he has very weak legs and
He drive?
he drives.
I was
Um,
about to ask, yeah.
he drives an automatic car, but he drives all over the place actually. And there has been some concern about that, but then there is also the conflict between the loss of independence by taking away his driving license, but the safety of his driving. And I wonder whether Kajal might tell us what you think we should be doing. Should we be getting a driving assessment on this man, either through occupational therapy, or what should we be doing?
Thank you, Jenny. So firstly, it's a very, very complex and yet very interesting case. Um, I was actually very surprised that he is actually still driving. If you're saying that it's difficult for him to even get up, and even to move, he needs to really hyperextend, and he's bending and he's using his truncle, to actually push him up. I'm very concerned on his ability to really press onto the brake, or even in terms of his reflex timing, given the multiple comorbids he has. So I would definitely send him for a driving assessment. I think it's balancing independence versus safety, and really not just his safety, but also the safety of other road users on the road. So I would definitely send him, at least in Malaysia, when we send our older patients with dementia, it does not have any legal implications. So, whatever the assessment is, we will talk to the patient, say, the reflexes are slow. The therapist does not feel you're very safe on the road. And so we will slowly talk them to, instead of driving out very far, just drive within the residential area, and then tell the family that, slowly, let's get it 1 week, once, twice, and then slowly. Usually one of the easiest ways is also to see if he has got into any minor road traffic accidents, simple ones, because sometimes it's just gauging the distance, driving through some streets. And if he already had that, usually can use that as a buy-in, that, you see, you've already had a few minor, but you were safe, but this can potentially lead to something more major, not for you, but even for other road users. So I would be really concerned if he's driving, given he has got some really bad weakness. But having said that, if the assessment is good, and, I mean, he's okay to be driving, then maybe getting some modification in the car that can assist him to, I also want him to remain independent, but at the same time, not really compromising the safety of the other road users.
Thanks, Kajal. In the interest of time, I might move on to the second issue, which was his long-standing sexual health and erectile dysfunction issue. And as Daniel pointed out, he has really sought advice and tried a number of different strategies. And I just wondered, maybe Barry, might be able to answer this question is how do we provide some sexual counseling so that we could navigate sexual satisfaction in the relationship that may not actually involve penetration or whatever. So how do we actually do that, and what would be your recommendations for that?
I guess there would be two different things that we might need to see. I think like one of the thing is the actual process of sexual process. I mean like how they interacting. That's more like a relationship based issue. But there could be I mean on the other side, I mean from a psychological perspective, there could be like unhelpful beliefs or thoughts about sex. Like we might have some beliefs about how sex should be carried out. Like penetrative sex might be like a type of like a mainstream kind of thinking about sex should be. So these kind of beliefs might shape how we think sex should be performed in a particular way. And these unhelpful beliefs might actually lead to anxiety. And especially these anxiety would probably affect males' erectile functioning and also how they enjoy sex. So these kind of unhelpful beliefs would also be like things that psychologists will be able to help to challenge with CBT kind of therapy. But on the other hand, we might also look into the relationship and see if things might be, I mean, there could be any other thing that we can do to help them to nurture from a more relationship kind of therapy kind of perspective to see that it may be a good way to help them to talk about sex as well in the therapy room. So they will be able to talk about their expectations about sex, and they might be also using these kind of talks to challenge the perception about how they would be able to perform sex in a good way. So I think it would be like what we could, I mean, on a more relationship based or a psychopathological perspective to see things would be like to help them to unwrap, to unpackage the unhelpful beliefs around sex or the expectation about sex. And then they will be able to find a new way to enjoy sex in a way that they would be they would feel pleasurable. If that makes some sense.
Thanks, Barry. That was what I wanted to hear, that we could do something, hopefully, about
Yeah,
that.
I think there is always things that we can do. I mean, from a psychological perspective,
Yeah,
to see how they could. I mean, to help them to facilitate their enjoyable sex life. Yeah.
great. Thank you. Look, if we just move finally to the bladder and bowel function, we're really running short on time. Um, I'm wondering whether anybody, what strategies can we use for or to assist somebody that has urge urinary incontinence and potentially polyuria or frequency of micturition, who has significant mobility issues. You know, there's male incontinence pads, etc. But what is the role of pelvic floor exercise? Is there a role for pelvic floor exercises to try to help with better control, if that is possible, or with his all of his other comorbidities, is that just going to be a um, non-reversible issue? And the same with the bowel function. Would pelvic floor exercises help that pelvic floor dyssynergia, which is a word I'd not heard of before? Um, would that help? Or, should we be ensuring the dietitian is making sure he has a high fiber diet, so has reasonable stool consistency to help with his bowel function? Does anybody want to contribute to that? I don't know. What about Kajal? What would you do?
So I think the first important question to ask is really what pathology is happening, what really is driving this issue. Yes, there could be um, prostate issues, there could be a bit of an urge incontinence. There could also be overactive bladder, which is driving his frequency and, him wanting to pee more. Um, and of course, the medications are not helping because it's an empagliflozin, which we will just need to weigh the risk and the benefit. So number one, I think if we can just have a urodynamic study to really figure what the pathology is, because Kegels would probably work very much if the problem is really in terms of the muscles, like in stress incontinence. But in people who have got, say, overactive bladder, then maybe not
Not
as
going
much,
to.
to be honest. You can get them to see physiotherapy. So then with the biofeedback, they can train a little bit, but not really. But if for overactive bladder, for example, we do have some drugs which actually work quite well in the general population who don't have so much of drugs. Because now my concern is really the drug-drug interaction by us just adding more and more pills. But like mirabrigon really works very well for overactive bladder. So I think it's more important to figure out really what the problem is and then going down. If it's truly stress, pelvic floor weakness, then really Kegels will help. The other thing is I'm also a bit concerned if he's going to be walking every time to the toilet, to actually pass urine, his risk of fall is really, really high, and it can be quite an injurious fall if he actually has a fall in the toilet. Whether or not he wants to consider having like a urinal and like timed voiding. So, every 2 hours, just void, pick the urinal, just empty your bladder, basically just to retrain a little bit. But I don't think I have anything else to add on.
Okay. Thanks, Kajal. What about you, Tristan? Do you have anything to add about the bladder and bowel function that we should be doing for our aging male population?
No, I don't think so. I just think it was fantastic and wonderfully presented case. And it really does cover so many of the aspects that I touched on. And also, it's very reflective of some of the most common things we've seen in our own aging and frailty service. I mean, we really struggle actually to get good psychosexual support. That's the thing that's come through most strongly for me. And Barry, thank you very much for your answer there. It was really interesting to hear you talk about that aspect. But we rely heavily on our continence nurse specialists, Jenny, who are not based in our HIV service, but are very willing to take referrals from us and very helpful and supportive in terms of arranging other investigations and ongoing support. But bladder and bowel issues, actually, continence issues, came up as one of the most common things that we were picking up in the early stages of running the SAGE clinic. And it's interesting how just by introducing, by feeding that back to your HIV team, and people just not even having to refer on for a comprehensive geriatric assessment, but just by introducing some regular questioning into their usual HIV consults, they can pick up on issues that can be referred on, people can be supported with, and this can greatly improve health-related quality of life. And we were aware that these were not questions that most people were asking in a regular HIV consultation, but actually really simple to ask about, and uncovered a lot of morbidity that was affecting people's quality of life and couldn't always be simply fixed, but certainly could be referred on for some additional support. So yeah, really good to see that presented as part of this case as well.
Thank you. Thanks, Tristan. Daniel, did you want to add anything else at this point to the case or to any of the discussion?
Well, I just want to say thank you everyone for your ideas. It is obviously very complicated, and there were actually a lot of ideas and issues that and solutions I guess I hadn't thought of that to reflect on, which is uh, good. I guess actually the only thing I was going to add was actually a more question maybe for you, Jenny and Tristan, just about because this patient has asked me before specifically about if there are any evidence-based interventions out there for lipodystrophy because part of his mobility problem is the weakness, the muscle waste in the limbs, but he's got this big gut from his lipodystrophy. He specifically asked me about the use of GLP-1 receptor antagonists, like the Ozempic, semaglutide kind of things, which I said to him that will probably worsen your muscle weakness problem. But is there anything in that space that has been shown to be helpful for that?
Daniel, I gave him exactly the same answer when he asked me that question. And very concerned about the use of the GLP-1 receptor agonists in people with significant sarcopenia. We know from the trials that you get a little bit of loss of muscle mass, but in those trials they were in fitter, weller people, and so the functional outcome of that minor muscle loss was not significant. But for somebody with really severe sarcopenia, I just would be incredibly worried. Tristan, what were you
I
going
would
to
echo
say?
that. Yeah, no, I would totally agree. I think the GLP-1 advice is completely right. We don't have any good data, in someone like this. Unfortunately, it'd be nice to have a really easy fix. There was some work looking at the use of growth hormone analogs and GnRH analogs a while back that seemed to be a little bit helpful, but none of that, as far as I'm aware, has ever translated into clinical practice or guidelines. So I really, I think we are often stuck in HIV with this mixed messaging where we say to people, you can live a normal life with HIV, get tested, but it doesn't reflect the lived experience of people, particularly those who were diagnosed before 1996, like this man. And I think it's very important that we keep presenting cases like this, because this is why we still need to make the case for further research, dedicated specialist services, and we need to remember that many people bear the scars of the legacy of those early days, including this man with lipohypertrophy, and other related issues. So thank you again for this great case.
Thank you.
Thank you. And I'd like to thank Daniel for presenting the case as well. It was a really great case presentation. I might hand back to Pui Ling.
Thank you. Well, thank you so much, everyone. I think we can all agree that it's been a very interesting discussion, and I certainly have learned a lot from this. So thank you once again to Daniel and to Tristan, and also for Jenny for moderating, and our hub members for all their input. Before we wrap up, I'll just hand over to Farah for any final announcements.
Yes, thank you, Freely. Hold on, yeah. I just have a few announcements to make. Just to remember for the Malaysian clinicians to fill up the Google form that I've shared in the chat box to claim for the CPD points. And then just to share with you guys what's coming up next for the next 3 sessions. So we'll have women's health for the June session, and then after that we'll be developing a clinic with integrated care and also advanced care planning. So these are all the didactic lead that we have secured for the sessions. So we look forward for you all to join these sessions as well. Yeah, and then to remind you all to fill up the feedback form. You can scan this QR code, or as well you can go on IACO platform to fill up the feedback form. So the certificates of attendance will only be given after you fill up this feedback form. So yeah, I think that's all for the announcement. I guess we really look forward for you guys to attend the 3 other sessions as well. Going back to Pui.
Okay, so thanks, Farah. So I guess with that, we'll draw the session to a close, and I hope to see you guys next month. All right.
Thanks
Bye.
so much.
Thank you so
Bye.
much.
Thanks,
Thank you,
Tristan.
everyone.
Bye.
Thank
Good night.
you.
Right, thank you, everyone.